hand surgery. Oh, lots of hand surgery, lots of shoulder surgery. Oh, I'll just hit. I'll hit return. No, it does not. No, I'm going to have to escape out. Got it. And then hit play. But then I do reconstructive ankle surgery, ankle fusions, knee arthroscopies, meniscal repairs, those sort of things as well. So being in a regional area, I'm very pleased that I have fairly broad practice, but today I really wanted to hit home a few messages about hand problems. So according to RACGP or our training colleges, we need to have some learning outcomes. Please note the learning outcomes. So first of all, obviously I'm going to talk about carpal tunnel, which allows us to assess someone presenting with finger paresthesia and numbness. I also want to talk about the current and traditional treatment options for trigger finger Dupoytrens and carpal tunnel. And then I have got some information about post-operative care and rehab, but if I'm not quite diving into that enough and you've got some questions, please don't hesitate to ask. So instead of giving you the classic story of carpal tunnel, I want to tell you what I see. And so I've got a private practice and I see a lot of regional patients. So I typically see a 70-year-old retired cane farmer. He's got these great big strong hands. He's worked hard all his life and he's had symptoms on and off for about 10 years. And then in the last 3, usually 6 weeks, he's had an acute deterioration. And what I mean by that is suddenly he is waking up at night. He's driving the whole household completely nuts because he's pacing up and down the hallway. He's running his hands under the tap. He's beside himself in the middle of the night. They get pins and needles, and carpal tunnel is the median nerve. So it's the radial 3.5 fingers. So thumb, index, and middle fingers. So just think of the thumb. They often have, sometimes they'll say it's the middle 3, sometimes they say it's radial 4, and occasionally they will include the little finger. When the little finger starts getting into the equation, I start thinking about the ulnar nerve, which is the other half of the hand, or the other fifth of the hand. But they describe pins and needles. If they put up with it for long enough, they describe a burning pain that starts radiating up their forearm. And I tend to find that people present when things start moving. So if they've got shoulder pain and it starts moving down their arm, or if they've got carpal tunnel hand pain and it starts moving up their arm, they really want to get something done about it. And they sometimes have tried other things. The steroid injections I find can be fantastically beneficial. I just want to draw your attention to the fact that you should try and minimise the number of times you give a carpal tunnel steroid injection. And the reason why I say that is I don't infrequently see patients who have had quite a number of them. So sometimes they come in and they've had 20 steroid injections and they've had 10 while they were living in Melbourne, and then they've come up here and they've moved to one town and they've seen a GP and had another 3 or 4, and then they've gone to another GP and had another 3 or 4. So just pop in the back of your mind that if they're sort of getting up to 20 steroid injections in their body, then it's time to start thinking about avascular process of the hip or shoulder. And so I just want to flag that as a possibility in your mind, because these patients are waiting for a long time to consider surgery. Anti-inflammatories might help. Sometimes they put topical anti-inflammatories might help. I like a night splint, and I've just given you a picture of one there. The concept is that they can't get their wrist flexed in the middle of the night, because obviously that's reproducing their Phelan's test. So they can't get their wrist down if they've got a bar, be it metal or plastic, holding their wrist in neutral. And I do ask them every time if they tried a night splint, and they will sometimes say things like, oh, I did, but it wasn't working, so I took it off, and then I realised it was working. So they'll have a narrative around whether or not the splint was useful. If they don't have a splint, they're often do all sorts of things. They tuck it under the pillow so that it's flat. They tuck it down their pajama bottoms. They get up to all sorts of things to try and keep that wrist in neutral, because they work out that that's the problem. So as far as an assessment of them goes, there's your history. I also ask them every time if they've got diabetes, because you just want to know if they've got a tendency towards a diabetic neuropathy. And it just, if they've got a diabetic component to it, I do have a conversation with them about their recovery time tends to be much more gradual, much slower. And they can get quite stiff hands after the surgery. And also just to tell them that I'm not fixing their diabetic neuropathy, I'm fixing the carpal tunnel contribution to their symptoms. So I just try and be clear about that. I also ask them about neck pathology. And what I mean by that is I ask about head injuries, because they sort of forget that, you know, they sometimes get like a neck injury, like a disc prolapse, but all they can remember is the significant head injury that they had at the time. So I do ask them about any neck pathology because I'm looking for radicular symptoms. On examination, it's pretty simplistic. I try and keep my carpal tunnel examination simple. If they've got thenar wasting, I've written here urgent. It's not really urgent. It's just I can't guarantee a recovery of that. So if it's got to the point that they're getting thenar wasting, then it's almost gone too far. So the urgency is that, you know, it's really worth referring preferably earlier, but it's worth referring at that point because you just want to make sure if they're going to get any recovery, this is sort of your last chance to get it. I recently had the opportunity to look up what a Phelan's test was, and I can't get a straight answer off Google, Dr. Google, but the concept is holding the wrists flexed. And the idea is you're sort of trying to recreate that position that they get into at nighttime. So basically the tendons are swollen up, the flexor retinaculum sits across the base of the palm and then kind of cheese-wise crushing those tendons, which are all tangled up with the nerve as well. So they're all traveling together in a cavity, and the flexor retinaculum will close off that cavity. So that's what Phelan's described carpal tunnel in 1946, which makes me wonder what on earth they did beforehand. But anyway, so he describes a test whereby you flex the wrist and you can leave it there for quite a while. And all I'm looking for is any alteration in sensation. Sometimes they'll, you know, you sort of chat away to them and then you say, can you feel a difference? And oh, yes, they notice that difference. Janelle's test is just tapping the nerve. If the nerve's irritable and swollen and, you know, surrounded by swollen tendons and you tap it, the patient will tell you that they can feel electric shocks. I usually try not to prompt them to say, do you feel an electric shock? But sometimes you have to say what you're looking for because they just know that you're hurting them and they don't really understand why. So I just want to give you a quick blurb about endoscopic carpal tunnel release, because the concept for an open carpal tunnel release is pretty simplistic. You just make an incision across the base of the palm, and what that's doing is that's dissecting in half that band, and it just pops apart, just increasing the volume of the carpal tunnel. So by just separating it by a couple of millimeters, you increase that volume 3 times as much. So I do keyhole surgery because, as I said before, as part of my training, this was the carpal tunnel release that I was actually taught, as opposed to the classical carpal tunnel release. And so I do keyhole surgery under a local anaesthetic predominantly. So the 70-year-old guy will come in. He's a bit disorientated because he's always a bit deaf because he's been sitting on a tractor for his whole career. And we get the whole team is kind of participates in trying to reassure the patient, educate the patient, keep them calm, because what I don't want them doing is I don't want them putting their blood pressure up, because if they put their blood pressure up, I can't see what I'm doing. So the patient has to be able to be informed about what might be going on. I put the local anaesthetic in, they go back to the waiting room, they sit there awake because it's a long-acting local, and then they come back, I put a tourniquet on their forearm, that stays on there for about 10 minutes. And I do a procedure whereby I make an incision in the palm of the hand and an incision at the base of the palm, and I actually pass a 5 millimeter trocar through there with a slot in it, and I've just got a little hook knife that I run across the flexor retinaculum. And if I'm operating on the left side, they can watch it on the screen. Most people say they don't really want to watch it, but we all like watching it pop apart, and everyone gets very excited. And so I put stitches in the palm and stitches at the base of the palm. And interestingly, I find that the older, so this now we're talking about post-op recovery, the older they are, the quicker they recover. And they love hearing that. The 70-year-olds love hearing that. So I find a 30-year-old will be very frightened about moving. And they'll be their expectations that they're going to be able to use their hand are way too high. They think they're going to be able to do the washing, the cooking, the cleaning, their activities of daily living, and go back to work the next day. And so they're really trying to use their hand. And I think 70-year-olds had pain before, they know what they're capable of. And so I think they sort of take it a bit easy on the first couple of days and then they get going. So it's at 1 week, a 70-year-old will make a tight fist, and they look slightly confused when I ask them to do it because they're like, oh, of course I can. And then a 30-year-old will usually at a week will kind of come in and go, oh, this is really heavy going. This is hard. And so if they come in and they're not really moving very much, I refer them across to the hand clinic, and the hand therapist will just build up that confidence. But I usually, if they're awake, I tell them to start moving their fingers on the operating table. So I just get them going straight away. And that builds into my personal philosophy about trying to make the downtime very short and trying to get even older people to get them back to doing what they normally do as quickly as possible. Most patients say that they had relief of symptoms overnight. Unfortunately, some people still have the local anaesthetic working. So they wake up and say, you know, the burning pain's gone, but I've still got a numb hand. So I just give everyone my mobile phone number and they send me a little text or they call my rooms and we just say, yeah, that's probably the local anaesthetic wearing off. And then I see them at a week. Most people at a week can demonstrate significant resolution of tingling and numbness, but sometimes they'll say that they've got some persistent numbness of the tip. So I just say, come back in 3 weeks and we'll just double check that it's sort of continuing its march off the end of your fingers. If they've had 12 months of heavy, dense symptomatology, then, 3 weeks is not quite enough for them to resolve their symptoms. And if they've got significant pre-existing diabetes as well, then 3 weeks is not quite long enough. I've included complications because I think we never like talking about them. And so I just want to be clear about what can go wrong. So with an endoscopic carpal tunnel, much more so than an open carpal tunnel release, it's possible to cut one of the nerves to the inside of the finger. Now, fortunately, the time that you do that is in your first 25 cases. So I think I'm outside the trouble zone, but there's a few tricks to making sure you don't do that. And so that's what I spend the whole operation not doing is, injuring that nerve. So that's the first thing to think about is nerve injury at the time of surgery. The second thing is infection. And to be honest, macerated wounds get infected. So the palm sweats. So I do encourage them to keep them dry and look after the wound. If they get an infection, they send me a photo on their phone. I prescribe them some oral antibiotics. It's just the same as if they had a cut on their hand and they had an infection. It's been a long time since I've seen a proper Flexitida synovitis or anything like that. CRPS is a complex regional pain syndrome, which is a whole pain syndrome which can be associated with carpal tunnel. And there's some theories about whether or not complex regional pain syndrome is really just an extreme version of carpal tunnel. And it should be relieved by a carpal tunnel release, but it is possible that some patients can get this syndrome in association. Some patients complain of scar thickening. I try and encourage them to use massage. There's another product called Cica Care, CICACARE, which is a silicone patch. And I find that's very helpful in softening up scars, particularly in palms. And they often get carpometacarpal joint pain. And I just reassure them that that's probably some arthritis. It doesn't like the fact that I've kind of changed the relationship between the bones of the wrist. And that takes a bit of bedding in. And it's probably the source of the problem. So it's probably carpal tunnel probably arises from CMCJ osteoarthritis. I'm going to pause for a question. Any questions? We've got carpal tunnel completely sussed. We know what we're going to tell our patients. All good. I can't see any hands and I can't see any chat populating. So I'm going to push on to trigger finger. But like I say, I can talk forever. So a trigger finger patient is someone who's too busy for this ridiculous problem. They wake at 2 o'clock in the morning with a finger that's jammed in this typical position. So what I'm saying is that the distal interphalangeal joint is not involved, but the proximal interphalangeal joint is the stuck joint. Initially, it just sort of jams and clicks and they kind of notice it on and off and it doesn't really bother them. And then one day it gets stuck and what they have to do is use the other finger to actively extend. So the flexor tendon is stuck and the extensor tendon is no longer strong enough to fully extend it. They can do it during the daytime if they really curl their fingers into a fist, if they've got a nasty one. Now, the image I've got there, what I'm trying to show you is that the whole concept is that the flexor tendon actually has to be anchored to the bone at a number of different points. So it's basically anchored at 4 main points between the palm and the fingertip. And so this is the first anchor point, the A1 pulley. And usually there's a whole lot of fluid around the A1 pulley and sometimes even that nodule that you can see in the picture. And so the nodule, what the nodule's doing is they've actively pulled that nodule past the pulley and now it's stuck on the other side of the pulley. And they have to force that nodule through the pulley, which apparently can be agonizing at the time. And so you can give them, where am I up to? You can give them a steroid injection. So the flexor tendon has a sac of fluid around it. So if it's just fluid that's stopping them from moving their finger, then the steroid injection is going to be fantastic. They think you're a genius, they're all happy. If it's actually swollen flexor tendon, well, you can give them as much steroid as you like. It won't necessarily shrink that back down. So a steroid is a great option, and I certainly encourage that for first presentation. The trick is inserting it not actually in the tendon, because theoretically that could cause a tendon rupture. You want to put it in the bag, the tendon sheath that is surrounding the finger. And what you're trying to do there is allow that fluid to settle back down again. Patients, like I say, my patients often come in with a splint that they fabricated, and sometimes they've got buddy strapping to try and stop themselves from allowing themselves to get full flexion. This splint that you can see here is just simply stopping the person from flexing. So the concept is that as they they can make a fist, but one finger sits up higher than the others because you're not allowing it to flex down. And sometimes that's effective just as a temporary measure. It settles down the inflammation and the whole problem goes away. So you're welcome to try that as well. So how do you assess these patients? Well, it's a bit awkward when they say, my finger locks up at 2 o'clock in the morning, can you fix it? And you need to sort of prove that they've got a trigger finger. So it's lovely if the patient can, show you their little trick movement, especially if you've got a medical student watching. Everyone comes racing in, we'll have a little look at this finger. They don't like repeating it too often, but you can sometimes get them to show a trigger finger. The other thing you can do is just palpate the A1 pulley, and they'll be really quite sensitive over that spot. And they're often a bit surprised because they think it's their knuckle joint up here that's the problem. And they're often quite surprised to find that they're actually very tender in the palm of their hand. And I've put weight here because, well, if it's not locking too badly today, well, can they wait until next month or 2 months? Can they wait to see if their tendon gets better? I'm just going to shrink this because for some reason I can't seem to get the chat. And, oh, here we go. Okay. There
are some questions come through, Sarah.
I know. I've just worked out how to get the chat up, but now I can't click on it because I can't get a mouse. That's very strange. Okay. Oh, nerve conduction studies. Oh, I'm terribly sorry. That's a very good point. Now, nerve conduction studies have 2 roles. One, they are required to get listed on the public hospital waiting system. And 2, they're useful for proving that a patient has carpal tunnel syndrome in work cover cases. Now, I don't think that an insurer should dictate a test. So I'm not always super keen. If they've got a perfectly clear carpal tunnel syndrome, all the signs and symptoms, and I'm confident about the diagnosis, then I am reluctant to encourage them to get nerve conduction studies. However, I do it begrudgingly if I get a particularly resistant caseworker. And so nerve conduction studies can be helpful in the diagnosis. The other time I like using it is when they come in with the little finger. So they come in with the little finger and I'm thinking, oh, I wonder if you're actually an ulnar nerve compression. So I just put some pressure on the ulnar nerve on the medial side, so on the little finger side of the elbow, and I hold pressure on that just like I do for the carpal tunnel to see if I think it's the little finger. If I'm completely lost, well, then I definitely send them for nerve conduction studies. However, poor Dr. McNabb says he always gets a bit nervous when I send referrals because I only send difficult ones. You know, he kind of has to really concentrate he knows I'm looking for that distinction. So yes, I do use it. Do I refer for steroid injection? Thanks, Aileen. I have an ultrasound machine in my room, so I don't have to refer for a steroid injection. I do most of them myself. My understanding is that there's some improved billing if they have CT scan guided injections, just for interest. But yes, I do the steroid injections for myself because I've got an ultrasound machine. Clarify, total of 3 in no. So yes, I agree with you. 3 steroid injections per joint is the rule. But what I'm trying to say is that when a patient says, can I have another steroid injection? Can I have another steroid injection? It's worth trying to find out if you're the person administering the 20th steroid injection or the 5th. And if you're starting to administer the 20th, then, you know, I think it's reasonable to refer and just find out whether or not this person has any other treatment options. Now, if they don't have any other options, well, fair enough, steroids are terrific. But what I do find, the other thing I ask them is I say, well, how long did the first one last? How long did the second one last? And sometimes the second's better, but sometimes the second's worse. And then we do the third one and, oh, that one didn't work. What they really mean is it only lasted a couple of weeks. And so if it's actually a diminishing length of time, well, that's another flag too. I guess I'm saying you need an opinion. How accessible nerve conduction studies for public patients? No comment. No comment. What about ultrasound instead of nerve conduction? Oh, exactly. Look, ultrasound for carpal tunnel is relatively new. My understanding is that there's no correct parameter to prove that someone has carpal tunnel. From my perspective as an orthopedic surgeon, the nerve doesn't look any bigger or smaller when they've got carpal tunnel. So I don't know that measuring their nerve size is an indicator of whether or not they've got compression, because it's not just the nerve getting compressed, it's the fact that the tendons are swelling up and down. It's the fact that the flexor retinaculum is getting stiffer as they get older. So it's a little bit of a difficult way to measure carpal tunnel. And I'm not sure that there's really good science around whether or not it's effective. Now, can you get away with an ultrasound instead of nerve conduction study with work cover? Probably. So maybe it's worth doing. But if you come back with a negative test, well, then you're probably going to have to send them for a nerve conduction studies anyway. But if that helps the patient, then that's fair enough. I do have another talk where I talk about work cover a bit more extensively, but the trick with work cover in carpal tunnel is trying to establish an injury. So I spend a bit of time with the patient trying to find out things like, oh, COVID hit, 3 people went home, my workload tripled, or I had this fantastic comfortable desk that I used for 25 years and then they put me in a corner with a laptop because so-and-so came in and we had to move offices or something. So it's important to try and get them to pin it down to why they got their carpal tunnel. All right, shall we push on? Trigger finger questions? Trigger finger's not as interesting, not as exciting. Okay, now I think I can see the chat, but I'll jump in and out when I notice a question. Please keep asking questions because I can't remember everything. So this is a trigger finger release. So basically I put local anesthetic in again. There's a theme here. I can do it under general anesthetic. Absolutely don't have a problem. And, I've just explained that. What I do is a transverse incision across the palm in the crease to make it look nice. And then I find the tendon. And what you can see in the middle of that picture, there is actually a shiny white longitudinal tendon. Now, it actually has a significant amount of synovium on it, which is making it that purplish colour. So I clear that off, and then either side of that is the digital nerves. So the tendon's smack bang in the middle, and then either side are your digital nerves and your digital arteries. So the whole point of the operation is to not cut the digital nerves. So what I need to do is just make a split longitudinally through the tendon sheath. Okay, so just very gently split that with a blade, and until it pops apart and I can see the tendon lying underneath. I then use that little rag nail, lift that up, and I run the scissors a little bit more proximally. You can't go crooked, you've got to go straight up the tendon. Then I lift up the other way and run them a little bit more, proximally and distally. And so the idea is to give that whole pulley, get that whole pulley released. If the patient's awake, I get them to move it. And then they say, oh, no, it doesn't hurt. And I go back and explain to them, no, hold on, is it locking? And then they realise that it's not locking. So that usually takes me, I don't know, maybe 10 minutes to sort of get from prepping to actually releasing the tendon. So by that time, they're still talking to the anaesthetic technician. So we have to interrupt the conversation and get them to show us that. So the reason why I mentioned the nerves is that's the number one complication, is hitting the nerve. And then the other one is recurrence. And I have had, out of 700 patients or something, I've had 2 recurrences. The first one, I still have no idea why it recurred. And the second one was in a diabetic, and she just couldn't get going fast enough. She had 2 trigger fingers, she had a stiff hand, she was frightened, she just didn't get rolling. And so, so she had a recurrence. When I go back in there, it's all sort of scarred back, it's all sitting back. It's a slightly bigger space, but it's all healed over the top. And I can't really give you a good answer for why it would recur. But if they come back and say it's clicking and catching again, I say, well, sorry, you've had a recurrence. It's time I'm happy to release it again. So there you go, trigger finger. Okay. Situation number 3. So the reason why I talk about trigger finger at the same time I talk about Dupuytren's contracture. Thanks, Ellie. The reason why I talk about the 2 is they are easily confused. And the secret is the Dupuytren's contracture is a gradually progressive disease where the finger gets stuck down. Now, a trigger finger, they'll usually be able to describe that it went backwards and forwards for a while before it got stuck. But I have seen both. I've seen both a trigger finger completely stuck, and I've seen a Dupuytren's contracture obviously flexed right down as well. So a Dupuytren's disease is a 60-year-old who had a lump in their palm 10 years ago and then suddenly noticed that they're poking themselves in their eye when they wash their face. And that is the most common presentation, is poking oneself in the eye. The other one is they can't get their hand into their pocket because the finger obstructs them putting their finger in the pocket. And bizarrely, these people have got significant finger deformities, and they are usually the only 2 complaints they have about their deformity. So what is Dupuytren's? Let's just see. Okay, what is Dupuytren's? Wait for the next cartoon. Dupuytren's is a disease of the fascia of the palm. So the palm has a white trampoline plate over it in the middle of the palm, and it protects the nerves and tendons and things from direct impact. So it's a protective layer. Bizarrely, there is a genetically predisposed group who will make that into a band of tissue that travels up the finger. So I like to think of it as like a benign tumour. It's an unrestrained growth. So it keeps growing and growing and growing. But it's not a tumour because it always grows in pretty much the same way. So it has directionality, which a tumour can't have. A tumour can only expand, whereas this thing forms bands. And the bands then wrap around the finger and bury themselves on the extensor tendon on the other side. And what they do is, as they tighten, they lift the nerve up until it's right underneath the skin. So this case on the picture is a particularly technically difficult one because the metacarpophalangeal joint is flexed up. So I then know that the digital nerve is going to be sitting almost under the skin. So it has traditionally been associated with alcohol. But one of the stories that I was told, and I'm not even sure if this is true, this might be an urban myth, was that the original study on Dupotrons, the major study, was done in Ireland, and it was done at the Guinness Brewery. And so they had a whole lot of people who had Dupuytren's contracture, and then they had a whole lot of people, the same people who had a bit of a problem with alcohol because they were paying them in beer. So if you worked at the Guinness Brewery, you were paid in beer at the end of the day. So the reason why I mention that is because it was an association, but it's not a causation. So they noticed in this particular study with a very limited population group that there was an association. Now, we call it the Viking disease nowadays because everyone likes to be told that they're actually a Viking. And so basically, it's got there's a huge incidence in Sweden and Northern Europe, and then there's a little smattering in Scotland, Northern England, and then a little bit of Northern Ireland, tiny bit of Northern France. I do sometimes get Sicilians who've got it, so I don't know quite how that happened, but it's often a Celtic type person. And I explain that to the patient, tell them all about it, because previously they'd come in a bit sensitive about the association with alcohol. Now, Dupuytren's contracture affects 3 sites: the palm, the sole of the foot, and the penis. I do not know what this picture has to do with anything, because allegedly this is something about medical education, but that just looks like that is not going to work. Okay, so I tell the patient that, show me your other hand and I'll show you that you've got the disease in this hand as well, because they'll say, oh no, I injured this or I cut my finger. I'll say, you've got it in both hands. And I say, if it affects your feet, it will feel like you've got a little stone under your foot. And then I say, it can affect your penis, but I don't need to see that. Go and see the penis doctor, please. So the problem with the penis is they see the penis when it's completely sideways. So that's why I tell them, oh, my internet connection's a bit unstable. Can you still hear me?
Yes.
Yes. That was awkward. So if it's presumably if they've got a very severe penile contracture, it's really challenging surgery to extract it. I've never seen it, but I can imagine. So what do we do for assessment? So obviously you take the history. You can explain the causation to the patient if you like. There's two things that I like to be sure about. The first one is that metacarpophalangeal joint, because that's in this point in the palm. The tabletop test is, can they put their hand flat on the table? So when it's just affecting this proximal joint here at the base of the finger, can you slide a pencil underneath their palm? And if I see them and it's a little bit early and they don't need much done, then I teach them that. I say, if you can't get your hand flat on the table, if you can run a whole pencil underneath your hand without you being able to touch the table, then it's time to come and see me again. The other one is the proximal interphalangeal joint, which is the first knuckle. So not the knuckle at the base of the finger, but the first knuckle. Once that hits about 60 degrees, so if that's 90, oh, sorry, got to get the other fingers out of that. If that's 90 degrees, once that hits about 60 degrees, I can't assure them that I can get the finger fully straight. Now, often they'll say to me, oh, of course not, that's fine, doctor. But it's nice to catch them at that 60 degree. So I had a lovely patient a couple of weeks ago. She came in with her finger stuck at 90 degrees. And in fact, it was 100 degrees. And she just said, look, I've been to see the GP and I just keep forgetting to mention it. And so she came in and it was really tough to get her out straight. And the joint itself starts to contract down. So the Dupuytren sits on the sort of relatively close to the surface, but the actual knuckle itself starts to tighten up. And that's hard for me to reverse. I've got to completely dismantle the knuckle. The other thing I like to know is the progression. So has this deteriorated such that this flexion, has that occurred in the last 2 months? Or has that occurred over the last 10 years? And if they struggle to answer that question, but if they're concerned that it's happened in the last few months, absolutely, that's time to seriously think about surgical treatment. So time to refer. So what do I do? Well, it's not a nice little tiny incision like the trigger finger. It's a big operation. And basically, I've got to start at the base of the palm, so the base of the band, and then I work I work gently, gently, gently all the way along the finger. And sometimes I end up all the way at the distal interphalangeal joint, depending on the type of contracture. So basically, I find the Dupuytren's band the whole way. I'm not sure if you can see in this image, you can actually see the digital nerve is kind of the last bit standing in that finger. So the skin flap's being peeled across, and just at the S of science, you can see there's a digital nerve there. Then there's the flexor tendon, which is completely uninvolved, is not involved in the process at all. And then the Dupuytren's will be what he's trying to dissect out with those scissors at the top there. So surgical removal of the entire length of the band from the palm along the finger, protecting the digital nerves, which is extremely challenging and mildly unpleasant at the time because, as I say, the Dupuytren's looks almost identical to nerve and it wraps around in all sorts of unpredictable directions. We then talk about doing what we call a fire break. So we take the skin and we kind of do a rotation flap to try and stop the band from forming with your theory that it's actually a skin condition rather than a fascia condition. So we've got lots of different skin flaps that we can use to try and turn width of the finger, loose skin of the finger into length, because all of a sudden we've got a finger that's been quite curled up and now it's fully straight. So that can be really tricky to get that. And I've put complications, but I like to monitor that wound. So I like to see it at 3 days, 5 days, 7 days, and then sort of take the stitches out at 10 days. So I like to keep a close eye on that wound. Look, it often heals beautifully. I mean, it's finger, it's got a great blood supply. I can't think of ever having to take them back to theatre or anything for an infection, but I worry about them and I keep a really close eye on those wounds. And so as far as, your post-operative assessment and rehabilitation, as we talked about with the learning objectives, watching the wound, keeping it clean and dry is pretty tricky for some patients. So, I appreciate if you're able to support me with that, particularly if they're regional. And then, getting it moving again. I'm genuinely surprised. They really get nice movement quite quickly. And they don't usually have terribly much pain. I try and discourage, that's a whole nother topic, but I try and discourage post-operative pain relief because I try and say to them, look, if it hurts, I want you to rest. I want you to just slow down a little bit. And these patients don't. These patients, despite the fact that I've completely dismantled half their finger, they don't seem to have pain. I've included this guy because it infuriates me that he's got bilateral, terrible Dupuytren's disease and he's never had surgery. And I've been watching them for years, hoping that one day he'll just, straighten out his fingers because someone sorted them out. But he may have actually had advice that he needs an amputation. And so I tend to say that to patients. Look, I say to them, look, do you think you'd really prefer an amputation? But the only time I've had that request is a patient who was in a nursing home and her fingernails were starting to curl into her palm and she was getting recurrent palmar infections because her Dupuytren's contracture was now so tight. And so that's a very reasonable, simple operation, local anaesthetic. She was demented, take the top of the finger off and then they can toilet her hand a bit more effectively. So complications, makes it sound like I take fingers off all the time. It's only after a fairly lengthy conversation do I sort of say, is this what you need? So once again, nerve injury, fingers, it's always all about the nerves. Recurrence, I do warn them, especially if they've got another hand, that they might get a recurrence. And they often if they get a recurrence, they can get a recurrence in the same finger, but it's a new band. And so they get all distressed because they've got recurrence. But in actual fact, I'll go back to my documentation and the band has started up in the next finger along and has managed to tangle across to the previous finger. So recurrence, the other thing I see is they get a really thick palmar skin. And so I treat that once again with the Sicker Care product. Wound infection, slow healing, I've already talked about that before, and flap death. Whenever you do a skin flap, you're always worried that it's going to die. So you just watch it like a hawk. The only thing, often see patients in the very early bands before a fixed flexion, correct. Patients often quite keen not to have anything done in the early phase. Is there a situation where it can be left as long? Yes, correct. Now, I do frequently see patients who've noticed lumps in their palm and want to get an opinion. The current the current thinking is that it's better to leave it longer. Okay, so initially Dupuytrens can be itchy and irritable and a little bit tender. And we think that's when it's in an active phase, when these bands are really expanding and growing. And the theory is that if you remove the Dupuytrens at that stage, the bands will continue to form. And then there's a thought that it gets to a static phase whereby everything's kind of not inflamed and irritable anymore. The band's been sitting there for a really long time, and that's the time to remove it. So definitely my preference is to leave it until they've got a significant deformity, because I know then that they've probably had it for quite a long time. Now, the other trick is to, if you don't want to get a recurrence, the trick is to do the operation late in your career. So if they get a recurrence in 10 years, you've already retired. But I think that might be cheating. So yes, so the reason why I tell that story is to try and say, yes, it's better to actually come in a bit later. So I don't want, so ideally you don't come in with it completely bent like this fellow, but if they're really starting to inch down and you're at 60 degrees, it's great. Is there any role for physio? Oh, in carpal tunnel. I was just going to say there's no role. I saw a paper recently and there is no role for physio in Dupuytrens, which I thought was really interesting. Role for physio in carpal tunnel. No, I've had lots of chats with physios about carpal tunnel. If you don't have an option, great. Give it a try. I don't really understand what a neural glide does. I mean, the nerve looks like it's moving when I look at it. Maybe, things like strengthening exercises are good. Is there some sort of role with the carpometacarpal joint? I just don't have any theories that would help me explain how physiotherapy would help. But so as far as physiotherapy and carpal tunnel, you are welcome to refer them. I just would rather I love physio for quadricep strengthening in knees. I love physio for posture correction in shoulders. When you've got 5 sessions, I like, to really hit them hard with some good sessions. I like back extension strengthening for backs. I like core stability strengthening for pelvic floor. I think they're the money ones. The carpal tunnel, I think save your physio referrals for something that you're more confident about. Basically, wait for the finger to start to get a flexion contracture. Yeah. So if the finger is fully straight, I probably don't really want to operate on that, even if they say they're sore. I'd like to see it when their finger starts bending down. So the tabletop test or the 60 degrees, fantastic. If you send me those, happy, I'll operate anytime. If you send me them and they're not too flexed up, I do the whole patient education and I say, you must come back if you notice the deformity. So, and I'm happy to follow them up and see them every 6 months, but it's not worth it because it can contract very quickly over a period of 2 or 3 months, or it can contract over 10 years. You're just not going to know. So that's why it's important as a GP to kind of keep one eye on it, because you'll be the one that'll spot it. Post-operative management, this is your learning objective, just in case you missed it. I like Panadol. I'm not a big fan of anti-inflammatories. Anti-inflammatories slow inflammation. Inflammation is required to progress to scar formation, to progress to bony union. Inflammation is a natural thing that is supposed to happen. Okay, so I'm not a big fan of anti-inflammatories. It's very useful for post-operative pain management because they have inflammation because they're trying to heal. So I prefer Panadol. I understand that's a controversial decision. Now, patients, have a mix of both. I'm happy for them to use either. I just warn them that if they're taking an anti-inflammatory and I've done a reconstructive procedure, it's potentially affecting the recovery time. I like the patient to have pain. I know that sounds very mean, but I like the patient to know if they're doing too much. If their fingers are sore, they need to elevate them. They need to start wiggling them, keep them up in the air. If it hurts when they put the hand down because all the blood is rushing into their hand, then they need to put the hand up and not take a Panadol. So I try and educate them about elevating the hand. The other call I do get, which worries me, is patients ring up and say, my hand is so sore. And I say to them, or they have a bilateral procedure and they say, my right hand's really sore, my left's not. And I'll say, hold on, I'll sit on the phone. Can you just take the bandages off? And they take the bandages off and they feel much better. So patients will tolerate very tight bandages. So do try and educate them. I give them patient information handout. Please take bandages off if they're too tight. Same with the plaster. The operation is not worth leaving on a tight bandage, okay? The patient's not going to wave their arm around and jump about just because you've taken their plaster off. But if they need constrictive circumferential plasters or bandages taken off, just take them off. Deal with the fallout later. Infection I usually treat with oral antibiotics. It's been a long time. I can't think of any admissions. If in doubt, phone your surgeon. This is my mobile phone number. Just give me a call. I don't mind. Call me anytime. Send me a text. I'm not great at waking up in the middle of the night, but I don't have many calls in the middle of the night. CRPS, chronic regional pain syndrome, is a painful, stiff, swollen hand. They really won't move and it goes blotchy, and they'll describe that to you. And so painful, swollen, stiff. Patients usually quite hysterical. They've never experienced a pain of this type before. Happy to do a whole talk on chronic regional pain syndrome another time. Okay. What kind of tree fits in a hand? Sorry, I've propped that incorrectly. Can I have some questions or patient examples or my favourite, difficult patients or complications or suggestions or advice for me? How are we going for time?